Hi guys, this is Dr. Lavanya here and I welcome you all to Pathway. I will be utilizing this platform mainly to teach the pathologists in the making. And I'll be using my favorite whiteboard and my whiteboard markers to do this job. So without talking too much, let's get to the video. So the topic we are going to discuss today is From Recent Advances 25th edition. And the topic is diagnostic challenges in endocervical adenocarcinoma. So today we will be discussing this topic under the following headings, that is classification. Firstly, the WHO 2020 classification of endocervical adenocarcinoma, and then we will skip on to precancerous lesions. Then we will discuss on HPV associated adenocarcinomas, and then we will be talking about HPV independent adenocarcinomas, and then we'll have an interesting few MCQs. So according to latest WHO 2020 classification, endocervical adenocarcinoma is divided into two types, that is HPV associated and HPV independent. Now the HPV associated one is further divided into usual type, villo-glandular variant, mucinous type, and adenocarcinoma NOS, that is not otherwise specified. And HPV independent endocervical adenocarcinoma is divided into gastric type, clear cell type, mesonephric carcinoma, endometrioid carcinoma, and again adenocarcinoma NOS, which is not coming in any of these categories. So coming to the precancerous lesions, I had said that endocervical adenocarcinoma is divided into HPV associated and HPV independent. So precancerous lesions are also divided by HPV associated and HPV independent. In HPV associated precancerous lesions, we have two types, that is adenocarcinoma in situ and SMILE. Sounds nice, but it is stratified mucin producing intraepithelial lesion. And in HPV independent, again we have two types, that is atypical lobular endocervical glandular hyperplasia. Once more, atypical lobular endocervical glandular hyperplasia, and GAIS, that is gastric type of adenocarcinoma in situ, because we said about gastric type of adenocarcinoma is coming under HPV independent. Now why I put A here is in the RA25 it is given only lobular endocervical glandular hyperplasia in the brackets, but I don't think that is justified because that is a benign lesion, so I just added A as a suffix to tell it is atypical, which is the precancerous part of it. We will be discussing every topics in 7 headings. So what are those headings? Firstly, I would need a definition or an intro at least for the topic or the heading or whatever you have given the subtitle. And then we will be telling about the etiopathogenesis. Then I need clinical features, and then we'll be discussing about the pathology, that is gross and microscopy, and then we will be telling about IHC, then we'll be telling about the TDs, and then treatment and prognosis. So these are the headings under which I would like to discuss topics. It's also to be put on that it's easy that you always make a structure in which you will write the answer and then you study also according to it, because it will be easier for your exams to always just have a structure and you just fill into it. So without talking much, let's come to the first topic, that is the precancerous lesions. I'll be discussing on the heading adenocarcinoma in situ. Adenocarcinoma in situ, mainly there is the glandular epithelium of the endocervix that is substituted by malignant epithelial cells. And then 2 points you have to put is that maintenance of the glandular architecture. So why you have to tell the maintenance of the architecture? Because this is an in situ lesion. And then it is associated with high risk HPV. Okay, so ma'am, now adenocarcinoma in situ, you said there is HPV associated and HPV independent also, but mostly it is high risk HPV associated. Why? Because you know that adenocarcinoma itself is 75% HPV associated and 10 to 25% is only independent of HPV infection. So in high risk HPV, so adenocarcinoma in situ also will be mostly high risk HPV associated. So from here HPV itself, you got the etiopathogenesis, that is high risk HPV virus 16, 18 and 45. Okay, now this is for HPV associated. Then what will be for HPV independent? You should always think why, and not only mug up whatever is written in your textbook or whatever books you refer. So if HPV associated, the cause is HPV, then what should be for HPV independent? As always, for any carcinomas, whatever you know, the first thing what you will be telling is mutations, that is genetic mutations. Okay, so that is about etiopathogenesis, and it mostly occurs in the age group of what? Okay, so you know that elderly people have usually CSRs, then precancerous lesions should come before that. Okay, so it will come in your 30 to 40 age group. And then clinical feature is that it is a precancerous lesion or it is an in situ lesion, so it is mostly asymptomatic and the patient only has an abnormal pap smear. So here comes the importance of pap smear screening. Adenocarcinoma in situ, IHC you will be doing mainly is P16 Inc 4A. Okay, and as I said that adenocarcinoma in situ is etiologically by high risk human papillomavirus. They show diffuse nucleocytoplasmic immunoreaction. That is, there is overexpression in the cytoplasm as well as there is diffuse nuclear block positivity. So P16 is the immunohistochemistry you do to identify HR, HPV mainly, high risk HPV mainly. So how does P16 get overexpressed when there is high risk HPV infection? Okay, you know that high risk HPV viruses produce E6, E7 protein and they act on RB gene and P53 gene to cause carcinogenesis. is there something related to that why P16 is overexpressed? Or do you remember in the cell cycle chapter where there is a diagram in the Robbins where there is cyclin D, E, A, B, and then there is one with P16, P17, P20, 21, etc. Do you remember? Then what is P16 there? P16 is cyclin dependent kinase inhibitor. Okay, and in that the INC4A family has P16. So now can you relate whether there is why there is P16 overexpression in HRHPV infection? Go find out yourself. And if you don't get the answer within 5 minutes, just write mechanism is unknown. As always, it's seen in the Robbins in many places that the pathogenesis is unknown. Okay, now let's come to the topic. So for P16, you see nuclear block positivity. Okay, that is one IHC. And then other which we will be doing is Ki67 or MIB1 index. So here the proliferation index will be more than 30%. You can write there is overexpression. And IHCs, it's always nuclear or cytoplasmic or both. So I said P16 is both. So Ki67, what it is? It's of course nuclear because it is a proliferation index. So it is related to nucleus. Then you will be doing P53. So P53 here, the importance is that it is focal. Focal, you have to stress upon that. Why? Because the main DD of adenocarcinoma is endometrial serous carcinoma. In this DD of endometrial serous carcinoma, there is strong P53 expression. So this is how you differentiate it from endocervical adenocarcinoma, because here there is only P53 focal expression. And now why you will keep it as a DD? Because the endometrial serous carcinoma can come and extend down to the endocervix, and that time your DD is endocervical adenocarcinoma as well as the endometrial carcinoma which has extended to the cervix. So P53 done. And the next is BCL2. So BCL2, it is an anti-apoptotic marker. So I said in this tumor there is more mitotic figures and apoptotic body. So if apoptosis should be this much, then what will be the BCL2 expression? It should be decreased, of course. And then there is vimentin. So what will be my vimentin here? It will be negative. And why I stressed upon that? Because in endometrial CA, vimentin is positive. Okay, so that is again another marker to differentiate endocervical adenocarcinoma from endometrial carcinoma. And then now we will come to the DD. So in the differential diagnosis, we have tubal metaplasia. Then we have endometrioid metaplasia. There is also an entity tubo-endometrial metaplasia if both coexist. And then superficial cervical endometriosis, which can look like endocervical adenocarcinoma. And then we have radiation therapy related changes. And then we have area stellar reaction. I'll be telling briefly about these things. So tubal metaplasia, as you know, you will see a fallopian tube like epithelial. And then in endometrioid metaplasia, it will be mucin depleted metaplasia, like mucin depleted columnar epithelium that you see in the endocervix. And then in cervical endometriosis, as you know, there is the endometrial glands and the stroma that you see in the cervix. And then superficial, why I stressed upon? Because this is adenocarcinoma in situ. If it is not invasion, so it's superficial endometriosis that comes as a DD for adenocarcinoma in situ. And then radiation therapy. In radiation therapy, you will see cytoplasmic vacuoles and pleomorphism, which can mimic adenocarcinoma in situ. And area stellar reaction, as you all know, area stellar reaction, the enlarged glandular cells also has vacuolated cytoplasm, and they have a hobnail appearance. and it's usually the superficial area that is involved, so it is also a DD for adenocarcinoma in situ. And then endometrioid metaplasia. Okay, so how do we differentiate endometrioid metaplasia from adenocarcinoma? It is the same as endometrial carcinoma, you have a DD. Endometrioid metaplasia, here it is metaplasia. Okay, so you will have bland nucleus, you're not going to have any atypia. And then your Ki67 will be low, of course. And then you will have BCL2 positive. Why? Because this is not a carcinoma or mutated specimen or an infected HPV specimen where you will have more apoptotic body. So the anti-apoptotic marker should obviously be increased. So this is how you differentiate these lesions from adenocarcinoma in situ. And then you should know why I discuss so much about DDs. In every other short notes we make, we'll just write DD as one or two things and just leave it. But here I will stress upon DD. You have to write it as much you can, because your topic, if the question is endocervical adenocarcinoma, it's of course easy to write. But then if the topic is diagnostic challenges in endocervical adenocarcinoma, what is the challenging thing in diagnosis? So that is how we can or cannot differentiate it from the other DDs of this lesion. So here the topic has significance for its DDs. And then I will tell what is cytology picture of it briefly. Okay, if you get short notes like glandular lesions in pap smear, etc., then that time you can write about this precancerous lesions. So in that, in adenocarcinoma in situ, in liquid based cytology on pap smear, you will get crowded sheets of hyperchromatic nuclei that I always said. And then the sheets will be composed of endocervical columnar cells, of course, and they will have pseudostratification, and there might be seen as rosette formation. So what is the treatment and prognosis of this lesion? Treatment is mainly conization, the con biopsy that you do, or else you can directly go for hysterectomy as well. So ma'am, why for a precursor lesion you are going for a hysterectomy? Because these lesions are usually multicentric in nature. So multicentric, because of that they can cause recurrence even after the conization. So it's better to go for hysterectomy if you are sure about adenocarcinoma in situ lesion. And then talking about SMILE, that I said, adenocarcinoma in situ, the other lesion which I said was stratified mucin secreting intraepithelial lesion. So it's almost same as AIS. The only thing is that there is stratification here. And because the stratification is almost similar to the squamous intraepithelial lesion, but except for the fact that it has conspicuous mucin production. And this mucin is seen as vacuoles or vacuoles in the cytoplasm, or it can be seen as cytoplasmic clearing. So now let's talk about endocervical adenocarcinoma, that is HPV associated. So talking generally about it, HPV associated. So the intro I will be telling is HPV associated. It is 60 to 75% of the cervical adenocarcinoma. So what is the rest? 10 to 25%? That will be HPV independent endocervical adenocarcinoma. And they are associated with squamous intraepithelial lesion or invasive squamous cell carcinoma. This point is important. In the recent advances edition, they have stressed this point in many places, because endocervical adenocarcinoma, imagine if you're having a squamous intraepithelial lesion or SCC associated with that, that means that if you have or diagnosis of adenocarcinoma, you should look for lesions where there is SIL or SCC in the adjacent ectocervix as well. And so you should not miss the diagnosis of SCC also associated with that. And then etiopathogenesis wise telling, this is obviously HPV associated, so HPV virus 16, 18 and 45. And the age group. For the precursor lesion I said 30 to 40. That is precursor. Then the actual cancer will be coming around 40 to 50 or 40 to 60 age group. And then the clinical feature is abnormal uterine bleeding. So the rest of the headings I'll be discussing according to the subtypes of adenocarcinoma HPV associated. In that, first one was usual type. So what was the classification if you want to revise it? It was usual type, mucinous type, glandular variant, and there was adenocarcinoma not otherwise specified, which I won't be telling because it is those carcinomas which is not included in any of these three. So usual type, why is it called usual type? It's basically this thing that we usually tell the conventional type or the classical type. That is why it is called usual type, because it is the most common type. It is 75% of the HPV associated adenocarcinoma, and it resembles endocervical glands itself. But I had said that endocervical glands are mucin secreting ciliated columnar, but here the difference is it is mucin depleted or poor in mucin. And then it is associated with HR-HPV, that is high risk HPV, that I had already said in the introduction that all these HPV associated are associated with 16, 18 and 45. And then now we'll talk about the gross and microscopy. Grossly, it is usually seen as an exophytic lesion. Exophytic lesion which will be seen as a polypoidal structure or as a papillary structure, or it can be seen also as a diffuse growth, or it's also seen in a minority of group as an ulcerating lesion. Now coming to its microscopy. As adenocarcinoma, it should be glandular in pattern. And in the glandular pattern, you will see well to moderately differentiated glands. And the glands are lined by, obviously I said, the endocervical glandular epithelium, that is a columnar epithelium which is mucin depleted, and you can see also irregular glands. And there is associated abundant fibrous stroma, and there is dense inflammation. So now each of the point I am stressing. Glandular differentiation, it is well to moderately differentiated. Usually they have better prognosis than the mucinous type, and then they have abundant fibrous stroma. Okay, now why is it important? While you're differentiating it from the endometrial adenocarcinoma, you always say in endometrial carcinoma, how do you differentiate it from endometrial hyperplasia? When there is back-to-back arrangement of glands and there is no stroma in it. So in contrast to the endometrial carcinoma, endocervical adenocarcinoma has abundant fibrous stroma, and there is inflammation also. So in the adenocarcinoma, if you want to differentiate it from the adenocarcinoma in situ lesion, in situ lesion there was no inflammation or desmoplastic reaction in the stroma. Okay. And then obviously you have associated mitotic figures and apoptotic bodies. As I said in AIS, in endocervical adenocarcinoma also you will get mitotic figures and apoptotic bodies. According to the figure system, the usual type of adenocarcinoma is divided into grade 1, grade 2 and grade 3. We know this classification mostly, that grade 1 is well differentiated, and then grade 2 is intermediately differentiated, and grade 3 is poorly differentiated. And grade 1, it has mainly glandular pattern, and there is less than 5% solid pattern. And in grade 3, there is more than 50% solid pattern. But here in this usual type, an endocervical adenocarcinoma, more important classification is the silver system. The silver system, it is a pattern based classification. So here it is divided into pattern A, pattern B and pattern C. So in pattern A, you see well demarcated glands, and then they are associated with dense inflammation, and there is no desmoplastic reaction. And then there is no complex growth pattern or any solid sheets, and there is no lymphovascular emboli as well. And in pattern B, there is tumor cell clusters. And they are separated from the round well demarcated glands. There is inflammation, and then there is desmoplastic stroma. But there is no solid growth. And lymphovascular emboli may be present or may not be present. And coming to pattern C has, obviously what is different from these two are now the solid growth pattern, or it can have a confluent growth pattern. Confluent means it has a complex papillary structure with mucin lakes, etc. And then here also lymphovascular invasion may be present or may not be present. Now coming to its IHC. IHC, as I said, for all HPV associated, we will be doing P16 Inc 4A. As a revision, I'll tell it is nucleocytoplasmic expression and diffuse nuclear block positivity you get. So it is diffuse and strong. Because why you have to differentiate it from endometrial carcinoma in that way. And then CEA is positive. And it is negative for Y-mentin, as I said, to differentiate it from endometrial carcinoma, and it is ER negative, PR negative, which are positive in endometrial carcinoma. Then cytologically, what do you see? Cytology is necessarily not mandatory to be written in endocervical adenocarcinoma. Long note, so much, but then if you have questions from pap smear, etc., you can add it. Right. And then you will see in cytology as 3D groups of the malignant cells. Sometimes you may see it as papillary pattern of arrangement of the malignant cells as well, and there will be nuclear pleomorphism along with macronucleoli. And the important thing is that you can see in the background there is a heavy blood staining, because of the patient has abnormal uterine bleeding, and then you have tumor diathesis. Tumor diathesis is a very important thing in background. We differentiate it from in situ lesions. Now we'll come to its DD. So coming to the DDs, think about the DDs. What will be the DDs it can have? DDs will be, first you will be discussing about the benign lesions, and then we'll come into the malignant lesions. Think about the benign lesions, the benign glandular lesions. So there can be microglandular hyperplasia. Usually it is seen in young women. And then there can be the laminar endocervical glandular hyperplasia. I guess you have seen endocervical glandular hyperplasia. If you have the endocervix like this, then you will see the endocervical glands. You can see as lobular. This is lobular endocervical glandular hyperplasia. And then if you are seeing it as a stream like this, all together like a sheet together, it is going on, then it is called laminar endocervical glandular hyperplasia. But then the glands will be very benign and bland nucleus, and there is no mitosis, apoptosis, etc. And then you have Nabothian cyst also, deep Nabothian cyst, if you confuse it. And then as said in AIS, radiation therapy and area stellar reaction. So these are the benign things which I said are the DDs. Now coming to the malignant DDs, as I said, always for endocervical adenocarcinoma, I was always keeping on telling that endometrial adenocarcinoma. The first main common DD is the endometrial adenocarcinoma. So the endometrial adenocarcinoma, you will differentiate it that it can have squamous metaplasia, forming histiocytes, and then you will see whether there is a endometrial lesion in the USG. Usually the endocervical extension, if the endometrial carcinoma has, that means if the endometrial carcinoma has extended to the endocervix, then by that time if the lesion in the endometrium itself will be almost crossing more than 50% of the myometrium. So it will be obvious that the patient itself has an endometrial carcinoma. Then you can use IHCs and all to differentiate. And the other one which is a differential diagnosis is metastatic adenocarcinoma. So metastatic endocervical adenocarcinoma will mostly have superficial location and they have well defined margins. Usually stromal reaction is absent. And usually they are from GIT, ovary or breast. And there can be also direct invasion. From where it will come? It should come from bladder or the bowel. So in such conditions, you will check for in situ lesions. Okay. So because if it is extension from the bladder or the bowel, you won't get any in situ lesion inside the cervix. So if there is presence of invasive carcinoma along with in situ lesion, then it should be obviously of primary endocervical origin. That is how you differentiate it from the other metastatic and invasive carcinomas from direct extension from the adjacent structures. Now coming to the prognosis and treatment. Prognosis, as you usually tell, it depends upon the tumor size, the depth of invasion, then lymph node involvement, the stage of the disease, and obviously the histological grade, the pattern. So treatment, if it is pattern A, you will go for conization. If you are taking the FIGO staging, then stage 1A or 1A, 1A1 or 1A2, you will do conization itself. And in pattern B and C or the higher stages, you will go for radical hysterectomy. And lymphadenectomy and chemoradiation. And we are pathologists. Why should we know about treatments? I always stress about knowing the treatment of the patient and the prognosis itself, because we should know the consequences of the diagnosis that we are giving. If it was someone of our relative only, we will come to understand the importance of how to know about the treatment, because then we will think, if I am giving a diagnosis like this, what if will be happening to the patient? Will she be undergoing surgery, or she can be treated conservatively, or she can be treated with radiation, and is it going to affect her life after that? It's very important for the pathologist to know about The consequence of the diagnosis that you are giving, and you should not see a slide as only as your case or as a slide. You should see it as a patient's life. So nextly we will be talking about the second one, that is the villo-glandular variant. So why you have 2-3 subtypes already, and then why we are putting this villo-glandular variant as a separate subtype? Because this villo-glandular variant has an excellent prognosis compared to the usual type, and it occurs in young women usually. I said the endocervical adenocarcinoma usual type occurs in 40s to 60s, but this one occurs in 35 to 45 age group. That is nearly to the same to the precancerous lesions. And then pathology wise, what you will see? Grossly you will see a friable polyp, maybe a papillary pattern also. And microscopically what you will see? As you can see in the name itself, it is the villo-glandular pattern, and I said excellent prognosis, so it should be well differentiated glands. And then it will be lined by usual endocervical or intestinal type of columnar epithelium. It can be endocervical, I said, because it is mucin depleted. You have to stress upon the usual type, and in villo-glandular type it is mucin depleted because you have a mucinous type in other one. So it can be either the mucin depleted columnar epithelium, or you can have an intestinal type of columnar epithelium. And then you will have superficial invasion. Invasion you have to comment upon, obviously, because this is a carcinoma, it is not an in situ lesion. Okay, and the rest wise, and the DD, you have Mullerian papilloma or adenofibroma. And compared to the villo-glandular adenocarcinoma, comparing to the usual type, they have minimal stroma. That is also important. I said endometrial adenocarcinoma is differentiated from endocervical by its very less stromal component. Similarly, in villo-glandular variant also the stroma is less compared to the usual type. And obviously the serous endometrial carcinoma, because that also has a villo-glandular look, so this can be a differential diagnosis, but then it will be more anaplastic and it will be poorly differentiated. But here the tumor is well differentiated. And then IHC, obviously I said, but we can discuss it once more. I'm going to revise it. That the IHC we will be telling about is P16 Inc 4A, which will be strong and diffuse, and which will be focal only in endometrial carcinoma. And this applies not only to villo-glandular, for all the HPV associated endocervical adenocarcinoma. And there will be HPV genotyping. If you do, you will get 16-18 in HPV testing, and then you will have Ki67 or MAB1 index, which will be high, obviously more. And then you will have TP53 negative, which is positive. That's P53 mutation is there in endometrial carcinoma, and ER/PR will be negative and Vimentin will be negative. Then to differentiate another thing from usual type is KRAS. KRAS is negative in villo-glandular variant, whereas in usual type mostly you might get KRAS positive. This is if we have a doubt in these two, in villo-glandular and usual type. And then treatment of villo-glandular variant is cone biopsy, because as I said, it has an excellent prognosis. So next we will discuss about endocervical adenocarcinoma HPV associated, which is mucinous type or the non-gastric type. Okay, now you should tell this third only, that is after usual and villo-glandular you will tell mucinous type. I agree that willow glandular is little rare, but then you are going to tell mucinous after usual type. Okay, why? Because when you scroll in Amazon or Myntra, what you will see first, most frequently viewed or mostly ordered thing. So likewise, then adenocarcinoma also the most common one is usual type and not the mucinous type. So you should write it in the order itself. Most common should come first, so that the examiner also understands that you know that you have seen cases like that. Okay, yeah, adenocarcinoma cases are little rare to be seen, but still. So usual type you are going to put it first, then glandular, then mucinous non-gastric type, and then adenocarcinoma NOS, which you will put at last, of course. So in mucinous non-gastric type there are 4 types, that is mucinous NOS, then there is intestinal, there is signet ring cell, and then there is stratified mucin producing. The stratified mucin producing can be written as ISMC, that is invasive stratified mucin producing carcinoma in short form. So mucinous NOS, it is similar to the normal endocervix because it is mucin secreting ciliated columnar epithelium, as I said. So it is also similar to the usual type. Only thing is that there is mucin, which is cytoplasmic. So it is mucinous adenocarcinoma only, but it is similar to the usual type of endocervical adenocarcinoma. Only difference is that it has mucin in it. And intestinal mucinous adenocarcinoma, obviously it is similar to the CA colon, that is adenocarcinoma colon. And then the thing is that it is pseudostratified. Now why I am stressing on this topic, this point, right? Because here there is stratified mucin producing. So the rest should be single layer or pseudostratified. So here it is single cells and here it is pseudostratified. And then signet ring cells, it's obviously individual or cell clusters. So pattern you will see is glandular pattern, of course. Or you can have complex pattern or papillary glandular pattern also. And it can infiltrate throughout the stroma. And then the thing is that because it is intestinal, so you can see goblet cells. Even in the adenocarcinoma in situ, also I said there is an intestinal variant of the precancerous lesion that has a goblet cell differentiation. And its DD, what it will be? Obviously, it is a metastatic adenocarcinoma from the intestine. And then IHC wise, they have CK7 positive and 20 negative and CDX2 negative. Okay, to differentiate it from the metastatic adenocarcinoma. And then obviously the another differentiation you are going to see is high risk HPV will be positive. That is P typing, or else you can use P16, that will be positive. And in signet ring cell type, there will be loose, non-cohesive cells, as you can see in every other signet ring cell carcinoma. And then there will be mucinous cytoplasm that will be seen as clearing or vacuoles. And then you will see it in singly or in nests or in clusters. and they should compose more than 50% of the tumor cells. That is also same in adenocarcinoma intestine also. That is more than 50% of the tumor cells should be having signet ring cell, to call it a signet ring cell type. And obviously the DD is metastatic carcinoma from the GIT. Then stratified mucin producing, it is associated with SMILE. As I said, the precursor lesion that will be there is stratified mucinous intraepithelial lesion. And then you will have invasive nests of tumor cells that has stratified epithelium, and they will be having obviously intracytoplasmic mucin, and there will be peripheral palissading. And compared to the rest of the mucinous carcinomas and usual types, they have a poor prognosis. So nextly we will be talking about the endocervical adenocarcinoma, which is HPV independent. So in that also I had said to you 4 types, that is gastric type, which I'll be discussing first. Then there is endometrioid mesonephric clear cell type, and obviously the adenocarcinoma endos, which I won't be discussing. So gastric type. Gastric type, why is it called gastric type? Because obviously it is the same as the mucinous adenocarcinoma, which is invasive, of course, but with gastric or pyloric differentiation. And there is also an extremely well differentiated variant for this tumor. It is called MDA, or adenoma malignum. What is MDA? Is minimally deviated adenocarcinoma. That means it's extremely well differentiated. Only minimal deviation is there. And this variant, that is MDA, is usually associated with Peutz-Jeghers syndrome with STK11 gene mutation. So etiopathologically speaking, I said you already there is one mutation about etiopathogenesis, which is not associated with HPV, of course. And then the age group it occurs, it has a wide variety of age, that is from 20 to 70, but mean age you can tell it occurs in the 40s. It is the mean age, but there is a wide range of age. And then clinical features, there is obviously abnormal uterine bleeding. Now pathologically, what is its gross feature? It can occur as a polypoidal lesion, or it can also occur as an ulcerative lesion. Usually the cervix wall is firm or indurated, and it has, as usually you tell, a tan white appearance that we tell in almost most of the lesions. And then histopathology or microscopy, you will see obviously glandular pattern, and the glands have single layer of columnar cells. With apical nucleus and basal nucleus, and it will obviously have inconspicuous nucleoli, as you see in the gastric glands. And the mucin can give it a clear cytoplasmic look. And obviously in 50% of cases, it is associated with vascular invasion or any perineural invasion. And you can also see the glands present near to the thick blood vessels are also considered as stromal invasion, and they spread to parametrium as well. So see how malignant they are. And the MDA variant of it, I said it's almost extremely well differentiated, so it looks almost like the normal endocervical glands that is invading into the stroma. But then how you can differentiate it from the normal endocervical hyperplasia or endocervical glands is that they extend beyond the level of normal endocervical glands. So ma'am, now approximately how can I tell about that? This approximation problem is always there. Like kind of in cooking also, when you ask your moms how much salt and how much sugar or so, how much spices you need, you put according to you need. You put according to how much you need. So you will be also thinking beyond the level of normal endocervical glands. If you have seen so many microscopies, you know almost how much endocervical glands you can see invading into the stroma. So if it is more than 8 millimeter from the surface, you should suspect a diagnosis of MDA. And I said you have to look for the Peutz-Jeghers syndrome. And now coming to its IHC. In IHC, obviously we said about the P16 will be negative or focal. Why? Because this is HPV independent. And then what you will see MUC6 positive. Okay, this is a gastric mucin immunophenotype. And differentiating it from endometrial carcinoma, it has CK7CEA positive, ERPR negative, and then P53 is also null. And then you can also do Alcian stain with PAS. You know why I am doing it is because there is a differential diagnosis of endocervicosis. Okay, so endocervicosis is something like endocervical glands going near to the to the urinary bladder. So in that case, how can you differentiate it from the MDA or gastric type of endocervical adenocarcinoma is that mucin. In the normal endocervical glands, the mucin is acid plus neutral. So it will give a purple to violet color. But if it is gastric type of mucin, you will get red color because it is only neutral mucin. So after the stains, we will be talking about the DDs of the gastric type of endocervical adenocarcinoma. In that you will have the usual glandular hyperplasia, the benign glandular hyperplasia. So that will include microglandular hyperplasia and lobular or laminar endocervical glandular hyperplasia. And then obviously I said about the endocervicosis, deep Nabothian cyst. Prognosis wise, they have worse prognosis than the usual type because they can metastasize to the abdomen or the peritoneum, and they have recurrence as well. Now we are going to clear cell type. So clear cell type, as the name suggests, clear cell. So you will be having adenocarcinoma with cuboidal cells with clear to granular eosinophilic cytoplasm. Ma'am, now it is clear cytoplasm, it should be right because it is clear cell type. Now you go and refer to the clear cell carcinomas of the body from head to toe. You will see a clear cell pattern. It is a clear to granular eosinophilic cytoplasm that you see. And then you can have hobnail appearance. And then the pattern is tubulocystic usually, or papillary or solid pattern. And they are similar to the clear cell carcinomas that you see in other parts of the FGT, that is in the ovary, endometrium or vagina. And it is also seen that people who have cervical clear cell carcinoma can have associated clear cell carcinomas in the other parts of the FGT. And then if you have heard about diethylstilbestrol, so clear cell carcinoma is associated with the intrauterine exposure of diethylstilbestrol, which is now banned in many countries. It was used before during pregnancy time as an anti-emetic drug. That time those female kids of those mothers who took this drug had clear cell adenocarcinomas. So coming to its IHC. Before telling about IHC, why it is clear cell. What is the clearing caused by? In mucin also I have said that there can be cytoplasmic clearing, but then in clear cell type, what is the thing which you'll get? If it is not mucin, then what is it? It is glycogen. So glycogen is the thing which causes eosinophilic granular or clear cell appearance to the clear cell carcinomas. So here in IHC, in contrast, you have P16 diffuse positivity. Now why is it so? Because I said P16 is CDK inhibitor. It is not something which is related to high risk HPV only. This is a protein which is already there in our body. So there should be a mechanism by which it is positive. So in clear cell carcinoma, you get P16 diffuse positive. But then if we do high risk HPV typing, it will be negative. And then here you have hepatocyte nuclear factor 1 beta positive, and then napsin A positive. You can get AMACR positive. Now so much of positivities I am not telling, this is more than enough, because here AMACR positive, why I said, because there is mesonephric carcinoma, which I said, which is again an HPV independent carcinoma, in which it is negative, but here in clear cell it is positive. And DDs of clear cell carcinomas are benign glandular lesions, that I said, microglandular hyperplasia, endocervical glandular hyperplasia, then area stellar reaction, and then in young children you can get a yolk sac tumor of cervix. But that how you will differentiate it from the clear cell carcinoma is like, because why this DD came is that I said that they are diethylstilbestrol when you are taking, those young women had infection, young women whose mother was exposed to that drug had clear cell carcinomas of the cervix. So that time if you are telling, if in that young age group, that is coming in the 19-20 kind of age group, that time the carcinomas which can occur in the cervix is yolk sac tumor. So how you will differentiate at that time? It is AFP positive, and then you will get Schiller dual bodies, etc. And then you can also have primary alveolar soft part sarcoma. If you can remember, you can write it, or else just leave it. So what are the treatment you give for clear cell type is radical hysterectomy, and vaginectomy or radiation. Why? Because prognosis is like bad prognosis because it can have lymph node metastasis, lung metastasis. That is why we are going for a high end of surgery. And then the prognosis depends upon the age, stage, etc. Older age group has better prognosis in this, because I said in younger age group, because of the DES exposure, it has a bad prognosis. So the third type we will be coming across is mesonephric carcinoma. So mesonephric carcinoma, it originates from mesonephric remnants. And grossly, it is seen in the cervical wall, lateral and posterior surface, and it is deeply invasive. That means it is a diffuse infiltrating lesion. You see more than an obvious growth. And histopathologically or in microscopy, you will see tubuloglandular pattern. The tubules and glands are lined by mucin-free cuboidal epithelium. Cuboidal epithelium, and it contains a bright pink to red hyaline material, which is its hallmark, which is Pars positive as well as mucicarmin positive. So you will see cuboidal epithelium, which is mucin free, and you will see the hallmark hyaline material. Now coming to its IHC, I said amaker negativitis, which is used to differentiate it from the clear cell carcinoma. So what is positive? CD10, GATA3. Differentiating from Vimentin is what you say it was negative in all the other endocervical carcinomas, but here it is positive. And then there is calretinin positive, EMA positive, and LMWCK positive. At least you should remember that there is Vimentin positivity here, which is an exception. And there is GATA3 and LMWCK positive. Okay, why are these things essential? Because the differential diagnosis mainly is mesonephric hyperplasia. So in hyperplasia, these things is used to differentiate it, because carcinoma is obviously deeply invasive and you should be able to pick it up. And in mutations, that is the etiopathogenesis of mesonephric carcinoma is that it has KRAS positive or NRAS positive. So that also you can do in IHC and see. And treatment wise, surgery is the mainstay of treatment, and they are clinically very aggressive. And usually they present at advanced stage and they can have a recurrence, etc. So other DD is clear cell carcinoma, which I said already. Now we'll come to the last type of the cervical adenocarcinoma, HPV independent, that is the endometrioid type. Why it is called endometrioid? Because it is similar to the primary adenocarcinoma of the uterine corpus, that is the endometrium. And it can usually arise from an endometriosis lesion. So obviously the DD is endometrial carcinoma, that is extending into the endocervix. Okay, I said about the endometrial carcinoma, which is already a DD of usual type of HPV independent also. So here, when you have to categorize it into endometrioid carcinoma, here you have to know that it is HR-HPV negative. This carcinoma, I mean the IHC will show P16 negative, obviously. Sorry, the IHC is P16 positive. Okay, that is in contrast to other HPV associated endocervical adenocarcinomas. You get P16 positive in HPV independent endocervical adenocarcinoma. So what is the difference? Difference is here. That is, it is P16 positive, but the HPV testing, if we do it, is negative. So based on different mechanisms, P16 is positive in this endometrioid carcinoma. But to type it as HPV independent, you have to get that HR-HPV is negative, or you can try for HPV genotyping, which will also come as negative. And ER-PR and Vimentin will be negative in this tumor, which will be positive in endometrial carcinoma. So let's come to the first MCQ. Which among these tumors has excellent prognosis? Usual type adenocarcinoma, mesonephric carcinoma, villoglandular endocervical carcinoma, or gastric type of adenocarcinoma? I'll give you 10 seconds. So what is the answer? Villoglantlar endocervical carcinoma. So the second question is, 40-year-old female, she came with dark brown pigmented spots on the lips and mucosa, had undergone hysterectomy for prolapse. And on histopathological examination, the cervix showed well differentiated branching glands that are extending 12 mm into the cervical stroma with numerous mitotic figures. So what is your answer? So what is the clinical presentation? Dark brown pigmentation. Usually it is a manifestation of Peutz-Jeghers syndrome. So I said about a carcinoma that is associated with PJS, that is extremely well differentiated variant of gastric type of endocervical HPV independent carcinoma, that is minimally deviated adenocarcinoma or adenoma malignum. So the third question is, 50-year-old female came with complaints of abnormal uterine bleeding, and on examination there was an endocervical growth. Surgery was done, and then the IHC was done as below. So you have to tell to me which is the tumor in each scenario. If the tumor was P16 high risk HPV positive, Vimentin negative, ER-PR negative, CEA positive, and stroma, what it would be? So the answer is endocervical adenocarcinoma, usual type. Because I said there is abundant stroma, and then P16 and high risk HPV is positive, and all these markers are negative. And in the second scenario, it is P16 and high risk HPV negative, but it is Vimentin positive and ERPR positive, and there is less to absent stroma. So it should be endometrial carcinoma. The next is P16 at high risk HPV negative but P16 positive and Vimentin and ER negative is endometrioid, endocervical carcinoma. Okay, I hope you people have understood the difference in this. So that's it, guys. I hope it was informative and helpful for you, especially for the exam going batch. So kindly like, share and subscribe for more videos and comment below your suggestions. So until I see you next time, it's me, Dr. Lavanya, signing off. Take care.